Sir, the discussion we thought we'll have mostly on this children having autistic spectrum disorder and those who are having neurodevelopmental disorder. And for last 10 years, we have been struggling in this domain when you were focused on mostly on the core psychiatry like schizophrenia, depression, suicide, so on, like anxiety disorder, dissociation and all. The children, as ma'am was presenting one of the domain of this thalassemia and how it can be integrated, care can be given under the same roof, whether in form of daycare or then translating, finding out these children and who are like selected candidate for the bone marrow transplant. Similarly, we had coincidentally has the similar presentation. We had prepared nicely what has been done in Nimhans, St. John's and CMC Vellore for these children, like early intervention, then the stimulations for different neurodevelopmental disorder, basically for autistic spectrum and other disorder. I think without PowerPoint also you can make a presentation and then we can utilize the time. And when you do a CME or workshop in future days, we can do it properly. If we allow, then can ask it.
Yes, sir, you introduce yourself. You are the first batch student here.
Very good afternoon to one and all. I'm very proud to be standing here because I'm the first batch of this college, and I feel proud to be an alumni from this institution. And a lot of teachers and a lot of people in the audience are my teachers, like starting from the first year with Jayanti ma'am till final year, including Ravan sir. So with this, I would like to start by saying that why did we choose like the topic for today is early intervention in autism spectrum disorder. So why did we choose this topic? You know, like psychiatry is something which is fascinating always, not just because we deal with the intangible, the mind, but also because the disorders and the diagnosis that we talk about is always debated. And it is more so in the case of children with autism. So when we talk about like not many years ago, we thought that the earth was flat, right? And most of our assumptions that we thought about earth depended on that principle that the earth is flat. And only recently, till we found evidence that earth is not flat, we started accepting it's round. And today, the scientific literature stands on the basis of that. Similarly, a lot of paradigm shift has happened with the understanding and conceptualization of autism. The first, I would say that the concept of the right brain and the wrong brain. Till today, we have been seeing that the brain needs to develop in a particular way so that we say it is a right brain, and then we need to say this is wrong, which is happening. There's more activation of this particular part. There is a deficit in this particular part. And then we try imposing the medical model of disability, saying that there are a lot of problems in this child and this child needs to be fixed. However, today, the world has gone from a medical model of disability to a social model of disability, where we can understand it in terms of a physical disability more commonly. Saying that, for example, a child has lost his leg. So what happens is, suppose we provide a wheelchair and we provide a ramp, the child is no longer disabled. So disabled is used as a verb and not necessarily it is the person carries the baggage of disability. So similarly, autism in the concept of the social model, it is like suppose a child who has autism does not get the right services and the right facilities, then the child gets disabled and is not able to function. That is the first concept. The second concept we talk about is the concept of neurodiversity. The slides are on. So we'll continue from that particular point only, like till what we discussed. So I thought of the schema of the presentation to be a paradigm shift, then talking about autism and neurodevelopmental disorders, then talking about early intervention. What about the Indian scenario? Some real-time videos about early intervention, and then what is the way ahead? I did talk about the round earth versus the flat earth concept and the typical brain versus the autistic brain. And what I've seen that this normal way of development is so much imposed by rightly by the pediatricians that we have to attain this particular milestone at this particular time and all that. At the same time, when we identify and we diagnose and we detect the child with autism, what services do we provide to the child is more important, and not necessarily only the diagnosis is something that is done with it. So today, with the awareness of autism, which has increased manifold, and the pediatricians across the globe have tried to identify autism at the earliest stage, starting from even 12 months and even 6 months, we start noticing some signs of autism. But the intervention that we talk about is something that is a bit difficult, because not because we don't understand what are the problems. We conceptualize autism as deficits. Like, for example, I'll talk about a child who presented to me, and he started saying that I'm 16 and I was diagnosed with autism last week. But I don't think it's a tragedy. I think it's the most beautiful feeling ever, because my entire paradigm of being a failed neurotypical person changed to a completely normal autistic person. So something that is this beneficial for me, how can it be a tragedy? How can it be something that everyone is so worried about? So he did go to Dr. Google, and Google will give it on list that autism spectrum disorder has executive dysfunction, sensory processing deficits, repetitive behavior, verbal, non-verbal, communication deficits, and a lot of deficits that the child has. To add to it, the psychiatrists across the globe, including the child psychiatrist, they have given a diagnostic criteria for autism spectrum disorder, which states that child has deficits in social and interpersonal communication. There are restricted and repetitive behaviors that we can see here. Then there is some sensory abnormalities. This may not be the diagnostic criteria, but a lot of children with autism have seen some sensory hyper or hyposensitivities. And then we have some extraordinary skills that the child may have, like savant abilities. Now, the second shift in paradigm happened when people started seeing that a person who is autistic does not necessarily mean that that person is disabled. That person is having a problem and we need to fix it. It is not necessarily that. And they started saying that all of it is a variation of neurodiversity. It is like, for example, we have different flora and fauna across the globe, and all of it is important for a good ecological system. Similarly, the variety of disorders that we today term as psychiatric disorders can fall under the concept of neurodiversity, and we need to actually understand them rather than just labeling, stigmatizing, and discriminating them. So what we thought about the normal way of development is actually now wrong, and there is no right or wrong way. This is just a different way. An autistic person is just different, and he has a different trajectory of development. Maybe he learns differently, he sees differently, he feels differently, and he communicates differently. So as I was talking about the social and the medical model, the social model says that suppose there is organizational and physical architectural disturbances are there, that causes the deficit. But in a medical model, we start to say that you are at problem, you are at fault, you don't have attention, you don't have communication abilities, you are poor in skills. That is what we try to do in the medical model. That puts a lot of burden on the child, and actually that causes even more stress. So suppose we give this example of a regular classroom versus a structured classroom. A child, if the child goes to a regular classroom who has autism, this is so chaotic. There are a lot of people there. It's so unpredictable. A child with autism will be definitely terrified by this. But if at all we provide an environment that caters to the child needs, like for example, it is structured, predictable, labeled, and a routine is followed, the child enjoys and the child learns like a normal child. So it is the environment which has to change in order to make the autistic child not disabled. At the end of it, actually, even at the end of it, the child will still remain autistic, but is no more disabled. This is what is the concept that is going on today of inclusive education. Next, when we see about the research in autism, we see around more than 70%, 60% of the research has gone into genetic and biological causes. Around 27% has gone to finding interventions, like what is wrong with this child, give some serotonin boosters or dopamine antagonists and clonidine and all that. A lot of research goes there, but very few amount of research, like some amount in neurodiversity, but even less, like less than 7% goes into the services that actually can help the autistic person not be disabled for life. So why does it matter? Like, what is the importance of all this? Because today in the globe, 1 in 50 people are autistic, 60% of autistic adults are underemployed, so 87% have mental illness, and 9 times they are more likely to die by suicide. And the life expectancy, this is a Western data, which is just 54 years, as across, this is the data of the UK, but the normal life expectancy is 85 years. So what about India? Does India also have studies? I'll talk about that in the next few slides. So then this some great important scientist, he came over and he said, see, this is not that autistic people have a problem in communication. It is a double empathy problem. It's just like birds of a feather flock together. Like people who think alike, they gel alike. So they started saying that a person who is autistic will communicate better with a person who is autistic, and vice versa. A non-autistic person communicates better with a non-autistic person. And this actually made sense because a lot of to the autistic community, this was actually something that was very relieving. They said, we are not a default because we are able to communicate, and our main means of communication, our ways of communication is different. So there was this famous Edinburgh study in which what they did, we all know about the famous Chinese whispers, where there are a group of people and a piece of information is circulated from one person to the other, and gradually they form a circle, and final person says what was the first thing said. So it is difficult to maintain accuracy there. We all know it. But what this study did, he said he divided groups into 3 groups. First, all autistic. The second, all non-autistic or typical. And the third, a group of mixed autistic and non-autistic people. So what was found in this was quite fascinating because we can see that in the non-autistic and the autistic groups, the results were almost similar and there was no difference. However, in the mixed category, there was a significant difference. So this started seeing that the concept of perhaps it is not that the autistic person only has the deficit. It is also a neurotypical person has a deficit in understanding what a person with autism is trying to communicate. So what happens here? As we can see, this person here is made to stand alone because he's different. That person faces a lot of, difficult kind of feelings which is not able to express, stigma and discrimination, resulting in a lot of anxiety, and a lot of behaviors which some are said as coping behaviors and a way of actually trying to cope with the anxiety, the stress. And initially what we thought about repetitive behaviors are always problematic. These days we have a bit modified concept to that. May not be always that it is bad. Some behaviors are actually adaptive and help in coping. So what is early intervention and why do we need to talk about it? So early intervention is actually something where we provide intervention at the earliest stage that is possible to help a child or a young adult or any disorder, a child with having any disorder to actually not go into the complications. It can be a child with neurodevelopmental disorder, with mental illness, or with having some cough or respiratory problems, or maybe having some addiction or gambling problems. So it prevents problems from occurring. It helps them to tackle when the problems come. The third thing is they have small solutions ready, like just then we put it in place, suppose this occurs, and rather than actually waiting for a later big solution, which will occur later. So what are the principles of early intervention? There are 3 basic principles in which we actually work today. The first is they say sensory processing is a bit different in children with autism. So that is when we talk about the sensory integration therapy. So what happens here? Okay, so what happens here, we see that all of us learn through senses. We are taught to learn that there are 5 senses, like the sight, the smell, the touch, the olfaction, and the gustatory. But actually in the world, the autism conceptualizes there are 7 senses. 2 additional are the vestibular senses and the joint or the proprioception senses. So what we do in a child with autism, we actually try to engage all the different senses that are there and integrate them so that the child learns better. That is what is done. The second figure that you can see that a lot of motor and lot of movement, kinetic kind of activities are there, which actually helps the child integrate and learn what a normal typical processing does not help him to learn. The next, we also say that the child has difficulties in having a lot of repetitive behaviors, and this repetitive behavior is something that needs to be corrected. But what we see that not necessarily all children who have these behavior problems or repetitive behavior is actually problematic. This is what we call as stereotypies or restricted behavior. When we ask the child to stop this behavior, like don't do it, the child does not know how to cope. The child does not know how to express that he is not comfortable. So what happens is in the process, the child loses imbalance and may actually have some psychiatric disorder like anxiety, depression, which also manifests in a different way. But for example, we give them to minimize the sensory system. We give them a earphone. We give them goggles so that the light does not cause hyperstimulation. child is better and the child is able to do things. And this repetitive behaviors, which sometimes seem innocuous, what is the need to stop all of it? So this is the debate that has been going on. And subsequently, what we have said is maybe we can actually allow the child to continue doing whatever repetitive activities that the child wants to do in a safe environment. For example, this child wants to study the train schedules, like something which is as simple as that. So what we can do is we can ask the child to do it in a particular time of the day and limit it at that particular point of the time, give a structure to the child so that at the end of it, maybe the child can actually do what he wants to do. And if we also regulate it at a point of time, we can see what beautiful and creative these children can actually give it back to us. So coming to the third point about applied behavior analysis, because we see that the children learn differently. Children in autism learn differently, be it the communication skills, be it the academic or cognitive abilities and whatever. So applied behavior analysis is another school of thought which tries to provide the services that is needed for the child to actually integrate back to society. And the most important or the most commonly which is widely accepted is the discrete trial method. So what happens here? We provide SD. SD is a discriminative stimulus. Like for example, I'm talking right now, I'm continuously talking, but a child with autism needs to differentiate what is a command from what is a background noise. And that has to be told to the child in a louder, in a clear and concise manner. If we do it, a child with autism will be able to follow it. Secondly, suppose we ask, I'll give you an example on the right side also. The second part is having a response. Like suppose we ask, where is your nose? The child is not pointing. So we can give a prompt, like here, and then the child does it. So obtaining a response with or without a prompt, that is the second part of it. And the third part, suppose the child does something which is desirable. We give a reinforcement. Reinforcement can be anything, depends on whatever the child likes, and it has to be valid. But suppose a child does something wrong, like we can correct it or maybe just ignore the response. We can say, no, this is not the nose. Let's try it again. And then where's the nose? And then we try to give a prompt so that the child has a corrective response. So when we see this discrete trial, there are three steps: providing the discriminative stimulus, second is eliciting a response, and third is getting the reinforcement or the correction. This is an example that
for generally and oral instruction, an SD can also be non-verbal, such as a picture, a toy like Mr. Potato has on a table, or the sound of swing. A good SDs follow several guidelines in order to be effective. First, all SDs should be clear and consistent. They should be free of extraneous information. And finally, they should be delivered in a voice slightly louder than a normal speaking tone. Now we will demonstrate what a good SD looks and sounds like. Yes.
So as we can see here, the child was actually made to sit in a calm, comfortable position and very clearly said, do this, 1, 2, 3. The stimulus was quite discriminative and was presented to the child. Then the child was asked to actually get a response and the child raised his hand. When the child did that, the therapist is actually providing a positive reinforcement by being happy, hugging the child or providing some good stimulus, maybe a tickling sensation here. So this is what the applied behavior analysis paradigm works on. So all of this sounds good, but do we have evidence for all of it? A lot of research has already gone into this three modes of treatment that I talked about: the applied behavior analysis, the sensory integration therapy, and the restricted repetitive behavior management. And the most common, which is practiced across the globe, is the ABA method. So what they did, they tried to divide into two groups. This is a Washington study. One group, they provided the early intervention. The other group, they just provided a community-based intervention. At the end of it, it was seen that a lot of children who were non-verbal at admission actually turned out to be verbal. Around 90% turned out to be verbal. As compared to, but children who were enrolled later, like after 5 years, they did not get much benefit. That is the importance of early intervention, because the brain is still neuroplastic to actually adapt and learn new methods of understanding. So as I talked about the research in India, these are the multiple studies which have been published in India supporting the efficacy of early interventions. And it is a combination of all the three different schools of thought that I said. So taking it forward, when we see that early intervention, is it actually helpful? Does it actually work? Yes, it works. And a lot of common questions is, do I need a diagnosis to start early intervention? No, you don't need to be diagnosed as autism or anything to start early intervention. It is for anyone who has a problem in processing the normal way, like normal or the typical way. Normal is something that we try to avoid because neurotypical and neurodiversity is the paradigm that we talk about. It is similar to the bi-gendered construct, which was there earlier, like the male and the female, and now the gender fluidity. Similarly, autism on one end, IDD, and ADHD and other disorders on one end, and the normal neurotypicals on one end, the entire thing is a neurodiversity spectrum. So way forward, what we can say is early intervention center, maybe at least we can start the first in the state here, because today it is not that these kind of therapies are not happening. They are happening, but they're not happening at one place. So a child has to move from one place to the other, and the entire day goes for the child in transportation and not actually receiving the benefit of the therapy. So maybe we can start with the early intervention center. It is not very expensive. It is not very difficult. It is just time intensive, and the person has to be committed. The person should work to love to work with children with autism and dedicated to the cause. So I would end to say that Earth is not flat and autism is definitely not a tragedy. So thank you. Floor is open for questions. A very interesting question. Shall I answer? A very interesting question. Actually, what we have seen is it is not advisable that a particular profession or a particular wing can take up therapy for autism. It is anyone and everyone who has the desire, the interest, and the passion to work for a child with autism can take up. It's not necessary to be a person who has psychology training, a speech language therapist training, or maybe occupational therapy training. It is not needed. Even parents who are illiterate, just educated up to standard 5, 4, 3, 2, 1. Even illiterate people can take up this treatment because the techniques I explained are that easy and that simple. But what you need to do is be persistent, be consistent, and the duration of treatment is quite important. It is 25 hours a week. That is 5 hours, 5 hours a day for 5 days a week. So that's quite intensive. It's almost like a school, parallel school running. Because it is that labor intensive, a lot of people are not able to do it. We just need to spread the awareness, because I'm definitely sure a lot of people in the general community will be willing to work for this particular autism treatment, and we can train them. It's not a very big thing. So thank you. Which professional careers? It's not important. Any professional career the person can take. Does not matter. So we have. Yes, sir. Yes, sir. I do have an answer to that. In the Western literature, what is there is not replicable in India. So a group of scientists in the South, led by Dr. Pratibha Karanth, she actually made a model where she tried to develop an indigenous model. It has been, all the papers that I published is from her model only. It is the COM deal model, or the communication deal model. It states that there are only 3 therapists that are needed. One is a speech language therapist, one is an occupational therapist or a behavior therapist, and the last is a psychologist. So these are the 3 people that are needed. And I have seen centers at Bangalore. So I was working at St. John's prior to coming here. So there are a lot of NGOs that work with parents and with people who are not trained, just 10th pass or maybe 8th pass, and they actually engage them. Yes, yes. And the training is of structured training is also available, sir. This COMDEAL provides a 6-month structured training for you. And if at all we want to make it affiliate with COMDEAL, they will supervise also the program for next 2 years. And then we also can train independently. And maybe I was thinking maybe the KISS students were there. So they are a good resource. We can actually generate a lot of manpower. And autism. Yes, sir. So a lot of patients are there. Like in the last 3 months that I have been here, I have seen at least 1 or 2 autism almost every week. So that's like 2 months. It's really high. That does not mean that we don't have autism. It's that we don't have services. Yes, sir. It's a 6-month training, and it is like 2 weeks they will go there, and the other days it is like, so it is structured. I'll provide you the details if you want. Child intervention is something, child psychiatry, child intervention. It cannot be a resource generating kind of a thing. It's something which is value addition. And Jyoti, St. John's, where I was there, they were taking around 300 per session, which is high. I understand it is not low, it's high. And
what about the IQ and EQ of these children?
yes, sir.
They are behind the normal IQ or EQ?
So there is a range. There are people who have low IQ who also have autism, and there are people who have extraordinary high IQ who also have autism. So IQ does not correlate with autism, sir. So that is what we call low functioning and high functioning autism.
You should have a separate class for the autism, or they should go study with others.
So inclusive education and inclusivity is what everyone propagates today. And it is only with inclusion that we'll be able to provide justice to the typicals and the non-neurotypicals as well. So inclusion is what we work towards.
Classroom teaching is now everywhere. The more the brave sport.
Yes, sir. Recently, KIT International School also signed a collaboration for special education. So for what we are talking about is making a child school ready. It is talking about the pre-linguistic skills and the pre-academic skills that we are talking about. Once the child is ready there, then they can go to the normal school.
Personal comments, which I hope the medical superintendent and Rahul will not take it seriously. But if you all go to the psychiatrist and have an evaluation of our personality and the mental condition, everybody will not be normal. And till my career of medical career, I have come across about 6, 7 psychiatrists who are very close to me. In BHU, they are also neighbor to me. 3 of them are neighbor to me. And I don't find that behavior, to my mind, that behavior is normal. And then the psychiatrist told me, you go to every day and evaluate the patient online. Then I told them, one day, he's very close to me, so somebody has some problem. What problem? We have to change your behavior. That I can do. And one day I went to his house and talked and have a cup of tea and talked to his wife. How's doctor? The answer was very sarcastic. The wife told her he's not normal, he's a mad person. This is the real fact. But what is that? It's the last 25 years, there is a dramatic increase in the treatment of psychiatry due to the invention of the new psychiatric drugs, and that has a tremendous increase. When as a student, there is a sedative and there is a electric shock. That was the treatment. Now it has all depending upon the new secretive agents, and that has one dramatic change. And what I think that the psychiatric and neurodevelopment, the neurodevelopment is a different part, the manifestation is a different. That manifestation should be evaluated in a proper manner, which should not be linked to the psychiatric part. That's it.
Yes, ma'am.
Because we don't have enough speech therapy centers. And that course is also not there in Odisha.
Ma'am, right now the ENT department has a speech and language therapist. Madam, cheap, but it is not well organized, not well marketed, and it is not very structured also that we can actually refer each and every patient. Follow up is the follow only. Maybe our hospital.
There are three types of courses, madam. There is a diploma course, then there is a degree course, there is a PG course. The diploma course started in SCB. There are 20 students per annum. Then degree, there is two private colleges in Odisha. One is the IHS, one is the IRS, something like that. There is a 4-year course. So after that, you have the PG in audio, PG in speech. So they have their scores, but we have kept a bachelor one and a diploma for the SCB for the speech. We have two people and they are doing. We need a like if you like to organize a center like that, you need a occupational therapist, you need a psychologist, you need a PG speech therapy. It should be a course like this. Then you can organize a thing and you can give a 6-month course like that. You can do in a hospital.
Ma'am, Odisha, actually, there is something called NIFTAR, ma'am. This National Institute of Rehabilitation, Training and Research, and that does good work for autism. They have everything comprehensive under one roof. The only problem is the child with the parent has to get admitted there, stay for 3 months, learn, go back. So that is the logistic difficulty. Otherwise, that is the only center which provides it under one roof.
Because somebody from Bhubaneswar is okay, they are coming, we are giving the time for 1 hour. But somebody from outside, he has to take the house, he has to stay here for 1 hour.
Does a medical entrance examination give relief to a student with autism? Right now, autism is included under the PWD Act, PWD Act. So as per that, the child can get benefit and the reservation category of disability. That is the only relief that the child gets. But SLD is something which has a very structured relief system, but not autism. It can be as per the Disability Act. In KIMS, we badly need a center. Everyday OPT encounter 1 to 2 child of this. Yeah, thank you, ma'am. Swahalata, ma'am.
Actually, same thing again I'm telling you. One step at a time. If you want to develop something, it doesn't happen overnight. And please form an interest group. Suppose an autism interest group or a speech therapy interest group. 4 or 5 of you or 7 of you meet once in a month. Over a cup of tea, discuss, then ideas will come. And like Rome was not built in a day, with small step will take you to the destination. यहाँ बैठ के सिर्फ इमेजिनेशन करने से कुछ नहीं होता. We should have like this, we should have like this, we should have the imagination. Doesn't happen. So everybody is not interested in every aspect. A cluster of people, like-minded people, must meet, sit down, then ideas will automatically flow. Then finance will not be a problem, institutional support will not be a problem. Okay?
आपण सर आग्रे बसले कंट्रोल करते से आपण yeah, I think her topic is early intervention. She spoke in length about that. The issue is that early intervention not only responsible required for autism disorder, it is there everywhere. Our NICU, they are doing a early intervention. The children are being followed up early intervention. Early intervention can be done for normal people also. Because if you have done a work on ICMR basis, they found that how early intervention was focused in children in our culture itself. They say what basically early intervention? Your brain 5 senses are very active that point of time when child is born. That 2 years synaptogenesis is the highest. So anything you stimulate, synaptogenesis will come up. That's the growth factor takes place. So basically, they say when the psychomotor massage is given by the mother, the bright clothes they wear, the bangles they wear, they stick to the child's face. These are early stimulations. These are a strong impact on child development in our culture. Unfortunately, this has died down, and most of the people are on nuclear family, this massage system, this bangles, these things have not come up. But it's a nice ICMR study, it has the Karnataka village, how this early intervention has helped people to grow, even those who have got mild disability comes up. Early intervention in our, how effective it is, just I can say, all the NICU graduates, we followed them for 3 years in a cohort. That's one of the postgraduate student from pediatrics. Base hospital took it. She took the study 3 years. Period was very less. To our surprise, except ICH grade 5 and connectors, all other children still 3 years, they don't have any disability. So that was the effect of early intervention. If anybody does it sincerely and regularly, it is the time, whether a child disability or no disability, about what DG sir told that we have to make a focus group. She has in fact made a proposal because just because of COVID we have stopped it, sir. We'll start an early intervention. We have got a resource person. Only it should be little regularized and put it in a systematic manner. Then only it will help. Because we have got clients, we have got people, and we have got occupational therapists, speech therapists, social and psychologists. Everybody is there. Just we have to integrate and make a group and start it. We will be starting it just after the COVID things goes on well. She has made a proposal to us, so we just wait for that. I think people have taken a lot of interest in this topic. Thank you.
Eloquent delivery, sir. She requires an applause. Only intervention is the order of the day. When it starts in the fetal period, that is a renewed awareness that the determinants of chronic diseases like hypertension, adult diseases, they are actually, it is programmed during this fetal development. Low birth weight, there is association between low birth weight babies and the subsequent development of adult diseases in later life, hypertension, cardiovascular diseases. So early intervention is the order of the day. Thank you.
Very nice presentation. Good.